Now, while we're all pretty sure the health department is doing everything it can to try and fix issues with the electronic vaccination data system, complaints keep pouring in from citizens who are still not getting confirmation SMSs. There appears to be some flaws with the EVDS. We don't know why it's not working, but Nicholas Crisp might. He's the Deputy Director General of the Health Department. He'll answer some of those questions. We've also got questions about the vaccines, the delays, the constraints we're facing. Along with him, Francois, who's a professor of medicine, who's from Ezintsha, is also on the line with me. So good to have both of you here, gentlemen. Let's start first with the EVDS. And maybe, Francois, what are you hearing about that system? Let's start with you. What are you hearing about the flaws with the system at the moment?
I think it's exactly what you've said, just a flood of anecdotes on social media, and then just my personal family and friendship circles are breakdowns in communication here. People who have registered who've had no acknowledgement, but also people who've been patiently waiting, playing by the rules, who haven't received their appointments. And I think increasingly people losing trust in the system because they don't know what's happening.
Dr. Crisp, what are the issues?
Thanks very much. So now we hear anecdotes as well, but for people who have registered, if they are not receiving SMSs, I would encourage them to go to the helpline and find out why not. That shouldn't be happening, and I'm actually frankly surprised because we are under the impression we've solved that challenge. As far as not receiving SMSs to come for vaccinations is concerned, that is wholly understandable. We have over 3.2 million people registered on the system, and we have vaccinated 1.1 million people, roundabout. So that means that we have got 2.2 million people in virtual queues at the moment. And so the system calls you to an appointment 3 days before now. It started off only 1 day before. Now it's 3 days before. And some of the queues are very long. And obviously there are not sites in every corner of the country. So you may have a particular site where people in that immediate drainage area might be queued with about 4,000 or 5,000 people to that site, and they may be seeing 200 or 300 a day at the moment. So until new sites are operationalized, the queue is very long, and if you're only getting called 3 days before, only the first 600 or 700 people would have received for that an SMS for that particular site. So, you can't expect to be called immediately when the queues are so long.
All right, we've got lots of anecdotes to say that things are not working. But let me ask you, why were you convinced that the EVDS was the best way forward in terms of this massive vaccination program?
Well, we have to account for over 40 million doses of vaccine, down to every single dose. With every person who gets it, we must be able to identify them. We must be able to account for the money that goes towards paying for the vaccinations. We must be able to address any potential adverse event, and so we must know which dose of which particular batch and lot was allocated to an individual. We must be able to call people to come for second doses. We must be able to communicate with them. And without an electronic system to communicate with 40 million people over this magnitude of project over a long space of time, and still account and report would be wholly impossible.
Francois, what's your view on that?
I think that we don't do that with any other vaccine in this country. And the Department of Health has acknowledged that this is a completely new system. I would just argue in an absolute emergency, is this the right time to pilot a new system? And secondly, why do we need this level of control over these 40 million vaccines? I agree that there needs to be a priority setting. I do think that there are operational issues around this. I don't understand this desperate need to control the system when we are in the midst of a third wave, that if we moved with a little bit more speed. I guess my question is, why are we so far behind? We have vaccinated only 1/50th of the population, a tiny fraction of the vulnerable, not a single person with a comorbidity. Why are we obsessing about trying to control the vaccine supply when we can't even get to the smallest percentage of people?
Well, that's a different issue, but let's ask Dr. Crisp to respond.
Yeah, you must be very careful about making statements that nobody with a comorbidity has been vaccinated. The vast majority of people over 60 do have one or more comorbidity. So clearly that was a decision of the Ministerial Advisory, or an advice of the Ministerial Advisory Committee on how to target which sections of the population we would get in the most vulnerable first. That's a different issue. The question of why we are not rolling out faster is purely because we have not been able to get the 1.1 million doses of Johnson & Johnson vaccine into the... We would have been using that 2 weeks ago if that was available to us. We would have been able to scale up more sites that were designated to receive the Johnson & Johnson vaccine, and we've been ready for a long time to use the vaccine.
You
so
say,
if we're not able to get that vaccine...
You say that we have this constraint, but remember that it was your department that turned away the AstraZeneca. Over 1 million doses of AstraZeneca were sent back, and yet we could have been started with that. I don't think we're a country that has the luxury of being able to say, not this, but this. Surely that was a mistake.
Well, if you're choosing a vaccine that is only going to be 20% effective in a country and you're going to spend that kind of money and effort to use it, I think that would be fruitless expenditure. And I'm pretty sure people would not be very impressed if we're not getting any kind of immunity out of a vaccine. So that's an issue also that the scientists and the people in the various advisory committees were advising on. And that decision was taken, that the vaccines that we are going to use are the Johnson & Johnson vaccine and the Pfizer vaccine. It's extremely unfortunate that it's out of our control that we've not been able to get the Johnson & Johnson vaccine into the system yet. And we were already hoping for clarification on that on Friday, and that's not the first time we've heard we'll get clarification.
But how is that a strategically sound decision to put all our eggs in the J&J basket? I mean, surely we know that because these are new, these vaccines are new, any number of things like this, any number of issues could crop up. And the more you put your eggs in one basket, the more vulnerable you are. But that sounds like we didn't do our scenario planning properly.
No, well, yeah, look, I think that is a very naive way of looking at things. Clearly, we don't have only one vaccine. We have two, Pfizer and J&J. And until the Sinovac was cleared, we didn't by the WHO as a vaccine for use in emergency. We didn't have a third option. That's still got to go through the regulator in South Africa. So it's not that we're not looking at all the potentials. It's just that there's no point in using a vaccine that's not going to give you the immunity that you need. So we don't have all our eggs in one basket.
Isn't the requirement that the vaccine prevents death and hospitalization? That's the primary requirement for a country like ours that doesn't have access to any and everything that we want, just because we do not have the kind of economic muscle. Now, you're saying the AstraZeneca, for example, was only 20% effective, but it would have prevented deaths and it would have prevented severe disease. So, and you said earlier that my perspective is naive. That sounds interesting.
Yeah, so I mean, it's naive to say that we've put all our eggs in one basket. Clearly, we haven't. We have interacted with Pfizer, we've interacted with J&J, we are working with the COVAX facility, and we're working with manufacturers of other vaccines as well.
And with COVAX, we've spent 280 million rand and haven't received a single dose yet. Is that correct?
Yeah, welcome to the real world. You see, this is the market in which we are competing, and that's the market in which we have to purchase from. So it's not that we haven't booked and placed orders for vaccines, but each of them has their constraints. But what I said you were naive about is having all our eggs in one basket. We don't have all our eggs in one basket. We have many routes that we have pursued, and some of them so far only the Pfizer one has been possible.
Well, it sounds like we have two routes, and a lot of our effort was focused on J&J, especially because of the convenience with J&J. It doesn't require the same temperatures, and now we're in trouble because we're not able to get the supply. Francois, you look like you're bursting to say something.
No, I think that you make the point correctly, is that first I need to correct Dr. Chris, is that the AstraZeneca vaccine provides amazing protection against severe illness and death. And we've published on the fact and the incoherence of the response in terms of sending away one of our critical arsenal, which is the AstraZeneca vaccine, which was being offered to us. We would have entered the third wave with 500,000 vulnerable South Africans vaccinated if we hadn't got some really bad scientific advice in terms of sending it away. And I still don't understand why that was done, because there's this veil of secrecy where none of us can see what those discussions were around the reasons for choosing one vaccine over the other. And we were sleeping at the wheel. We took months before we were starting to procure the vaccines. It took the president to actually intervene, and we only had them sort of received at the end of February, early March. So compared to other countries, we were asleep at the wheel in terms of acquisition. And now this is the concern, is that Pfizer is drip feeding us tiny numbers of vaccines, and J&J has a production issue, and suddenly we don't have. The reality on the ground is that we have entered the third wave, essentially unvaccinated as a country, where many other rich countries, you said, welcome to the real world. The real world was that we were ahead of the curve months ago. We were in a position to actually procure these vaccines. And now, as I said, we've got a tiny proportion of the people who need the vaccines have actually been vaccinated. We're going to be really lucky if there's a fourth wave to have a significant population of the population vaccinated at this rate.
Nicholas?
Yeah, well, there are many moving parts. I'm not a scientist, and I'm not part of the ministerial advisory committees, and I think that is something that happened some time ago, and it was a debate in the public space, which we all followed, and that decision was taken at that time. So now we sit where we are trying to operationalize, and you're asking me about what we're doing now, and I'm responding to what we are doing now. And now we are using every possible means we can to get every possible dose we can of what is approved for use in South Africa. And there are issues around the J&J, and there are issues around the flow of what we are able to order and have delivered on Pfizer. But every possible route has been explored, and we continue to pursue them.
So why is, as Francois say, why is information so opaque, so difficult to get to? Why is everything being held by the Department of Health so close to its chest, when we know that we have a very strong private sector that has looked after the health of many South Africans? Not all, absolutely. Government is by far the biggest healthcare provider, but we have the benefit of organized systems among private healthcare providers. Why are they not working more closely together?
They work very closely. I sit in all the meetings with them, and we have been having every day meetings in the afternoon with private sector at a very senior level. And now once a week we have very detailed operational levels. And on a daily basis, the teams that I work with in the Department of Health and the EVDS are working very, very closely with each of the sites to make sure that they are registered, that they have their necessary pharmacy licenses. We've done everything we can to accelerate their applications to the Pharmacy Council. In fact, I'm extremely pleased with the relationship we have with a very capable private sector, but they share the same constraints we have. And I don't have any problem with the way that we're working together with the private sector.
So the constraints, again, you go back to is saying we just don't have enough supply.
That's the bottom line.
And Sinopharm and Sputnik, when is that going to be released? I also understand there's a 10 million offer from Pfizer, 10 million doses that should be unlocked and ready to go. When is that going to happen?
Okay, that's been signed. So that one is on, that's now happening, and it's got to follow due process. But the signatures that were required to release that 10 million have been signed now. So that process is underway. As far as Sinopharm's concerned, my understanding is that we have now seen the statement from the World Health Organization. And SAHPRA, my last interaction with them there is that they are busy with those applications for the registering of the Sinopharm vaccine. And with Sputnik, I don't know how far. You would need to ask SAHPRA where that process is in the approval process.
Okay, there was a question earlier from Francois about the comorbidities, and you said, yes, 60 plus, but I know that originally phase 2 was meant to be 60 plus, but also people under 60 with dangerous comorbidities. And then that stopped for some reason. And there is, as you know, you said there are a large number of people over 60 who do have those comorbidities, but there are also, if you look at a 61-year-old fit person and you look at a 45-year-old person who might be obese with serious diabetes, they're probably at much more risk. What swung the decision to say the original plan to go after comorbidities under 60 must change? What swung that?
Yeah, so again, the advice that government gets and the advice that's given to the minister goes through a process of ministerial advisory committees. So scientists, epidemiologists, clinicians, and others take part in those meetings. And as far as I'm aware, Francois has been closer to that process than I have, so he may have a better inside track than I have. But it's based on that advice that we have to segment the population and choose priorities. And so what I'm aware of is that the decision was taken that if you only have so much vaccine, you go for the older folk first, because the concentration of comorbidities and age is where you are able to get your most intervention, and those are, as you said, the people who are most likely to be hospitalized and have severe infection. So there are other problems with getting people, when they register, to declare that they have one comorbidity or the other, because there's no way to verify that at the point of vaccination or even at registration, other than somebody's personal declaration. It's far more complicated to manage, and there are legal issues and ethical issues around collecting that data that is not necessary if we deal with only age as the criteria.
So, Francois, you would agree with that?
Well, firstly, I was kicked off the Ministerial Advisory Committee last year, so I'm not that close, unfortunately. I think that I'm aware that Dr. Crisp, I think, is correct, is that I think a simplified approach to this should have been taken, is we should have been vaccinating those below the age, over the age of 70, then dropped it to 60, then over the age of 50, and progressively done that. However, I also think that there could have been a situation where at primary healthcare clinics, where nurses, where these are being handed out, that the people with diabetes, with some of the comorbidities, could have been flagged and could have been vaccinated very quickly. Again, I'm just coming back to the point, though, is that it doesn't matter how you cut this cake. The people who are most vulnerable to disease in this country at the moment, which are the elderly and those with severe comorbidities, are almost all unvaccinated at this point. And that we need to be asking, I have a lot of sympathy, and I think there are lots of unsung heroes in the vaccination response in government, I mean, in the vaccination, the researchers, some of the advisors. But the bottom line is it doesn't matter if people are not getting the vaccines into arms. And we need to be focusing on how many people are being vaccinated every week. Every day that's gone past, we've vaccinated about a third of the people we need to. And that just means that the other two-thirds get kicked down the road and have to face the fourth wave and goodness knows how many other waves unvaccinated. So the question has to be, again and again, is how many vaccinations were given in the last week. And at the moment, from what I can see, we really are woefully going too slowly.
You said also, Francois, this is very important, because we're talking about constraint here. Dr. Crisp keeps mentioning we just don't have supply. Now, you said earlier that you'd done the research to prove that the AstraZeneca is effective from preventing dangerous levels of the virus in the body, or, to the point that it would kill someone, and it could prevent serious cases and therefore overwhelm the hospital system. Would you go back, Dr. Crisp, and start procuring even the AstraZeneca now? Whatever's available.
Yeah, well, that wouldn't be my choice. I mean, wouldn't be my decision. There are processes to that decision, but there's no reason why that decision could not be reconsidered by the Ministerial Advisory Committee. And if that is what they feel as the clinicians and scientists involved, then surely we would consider it.
Well, it sounds like for South Africans that makes sense, because President Biden, I know, is releasing huge numbers of that to, he says, the world. I don't know where we fit in when it comes to receiving that donation from the United States, but he mentioned a number like 80 million doses of AstraZeneca vaccine. Should we not be getting on our horse right now and going and putting our hand out and saying, yeah, we want them?
Well, right now we should be getting the vaccine that we've already paid for and paid the deposits, and that's the J&J vaccine and the remaining Pfizer vaccine. So in answer to Francois' question, at the moment we're vaccinating 70,000 a day on average, and we are capable today and for the past week of doing double that. So we are in a resource-constrained environment, and we have had to put the brake on both the provincial and the private sectors from expanding their platform, just because it is just not possible to get more vaccine into the process, into the, let's call it, the supply chain. We have enough to keep the flow running at the moment, and we can step up dramatically as soon as we know what the future of the J&J vaccine is.
But it sounds like, unfortunately, South Africans have to hear again and again that we are so reliant on J&J. You must have a plan B and C.
Well, that's the whole world has got a problem with J&J. This is not just us. And even here, the vaccine that is finished and filled in South Africa by our plant in Gqeberha is supplying to many countries around the world, and all those countries that were relying on that vaccine are in the same position as us. So that's not to say that we are not pursuing other options, and as I've mentioned, I know that the process of the Sinopharm is now being unlocked by the WHO a circular of support, and there we will consider all the vaccines, I'm sure. But as I said, I'm not the scientist who makes the recommendations, and I'm not in a position to say whether that is something that the scientists collectively will advise to the minister or otherwise.
And a question to both of you now. Let's start with you, Francois, on this. One of the challenges that we as South Africans have is that we don't seem to get enough information about what's going on in the back end to try and bring in the supply. You know, the Sinopharm, the Sputnik, the other available vaccines. It seems that the information is drip, drip. And how can we fix that? We need confidence. The country needs confidence that things are being done.
I think we need transparency. I mean, Dr. Crisp is right. He needs to take the best epidemiological and scientific advice and implement that. It's not on his shoulders to do that. And unfortunately, we don't know why those decisions were made, because the Vaccine Ministerial Advisory Committee discussions are not being made public. So a whole lot of inexplicable decisions get made, and we are not privy to those discussions. I was on the MAC, and part of my discomfort was a whole lot of decisions were being made that we were not being consulted on and seemed to have political basis at the time. This is not about vaccines. These were about policy decisions. And we were raising these in the MAC as problems, and yet they were made into policy, and then people would say, oh, we're following the science, when actually no such thing was being done. It seemed to be following the politics. So I just think South Africans need to be demanding radical transparency. There's no reason for us not to know the reasons behind it. And we may disagree, that's fine. But at least let's have the disagreement in public without this veil of secrecy around everything from procuring the vaccines to the reasons behind why we're using specific vaccines. We know that these companies have tremendous political power, and that the drip feeding to all the developing countries, including South Africa, has meant that we are way behind in the queue of priorities. So we have rich countries that are sitting on hordes of mountains of extra vaccines, while we are so far behind. Including, I think one of the things that Dr. Crisp needs to acknowledge is that even by African standards, we're far behind. And part of the reason is that we put our nose up at the AstraZeneca vaccine for reasons which are just unclear to me.
Do you acknowledge that, Dr. Crisp, that even in the African stakes, we're at the bottom of the log, and there's no reason that we should be?
We're near the bottom of the log. We're not anywhere near the bottom of the log, but we are not performing. I will accede that we are definitely not vaccinating the number of people we should be. But also remember that we purchase on the open market, whereas many other countries are part of the 92 that have a different route of supply through COVAX. And it's not comparable, what we are having to deal with and the way in which we have to interact with the international market. There are conditions to our procurement deals, and there are conditions around the way in which the supply is guaranteed and not guaranteed. And those are, some of them are problematic for all of us. But it doesn't mean that decisions of the MAC should not be consulted, or you shouldn't get somebody on this show to discuss with people who are involved in taking those decisions. It doesn't help to talk to people who are not involved in those decisions. So if Prof. Venter has got issues with the decisions that his colleagues are advising or feels that is inappropriate, that would be a discussion to have with those people. I don't sit in that forum, so it would be unfair of me to comment on that process.
The final question for you, Dr. Crisp. Do you have any idea what the roadblock is at COVAX, apart from the Serum Institute and AstraZeneca, which we know isn't the one that we've been procuring anyway? What's the roadblock? What's stopping it from functioning properly?
We don't know what the problem is. We had discussions on this pretty much every evening this past week, and we don't have a resolution on what exactly the problem is. But we are trying to get to the bottom of that to understand what's that problem.
Thank you for your time. Dr. Nicholas Crisp, who's Deputy Director General of the Department of Health, and Francois Venter, Professor Francois Venter from Ezintsha. A very, very productive and interesting conversation, and lots more to learn. I think we need to speak some more about these matters.